5% is one answer, but you are not yet close to the chocolate. Any other number? What is the prevalence of chlamydial infection among the 200 that we tested? Guess here, nobody is going to take you to task. $30? $35? $40? Little above 5%. Who said 9.5? All right. Now think this way. Let us say none of the 200 had chlamydial infection. Let us assume. And then we applied the test. How many of them would you expect to be test positive? 10 to be positive. Why? Because specificity is 95%. So 5% false positive, that is 10. What did you get? 10. So the true prevalence of the disease is 0%. Now, when you do a diagnostic test, you have to worry about false positivity. In other words, when you go for screening, the first thing that you notice is specificity. You ask the question, oh, specificity 90%. That means 10% is going to be positive. And the real prevalence will be anything above that. Now remember, Rajul talked about the dependence of the validity of a diagnostic test on the prevalence of the disease. It is so crucial. But what is prevalence of the disease? And we use the word pre-test probability. That is, when a patient comes to you and say, I got headache. At that point in time, you start setting your probabilities. For example, if a patient walks into you and you grab him and do a Vidal test, it is uninterpretable. Because of probability, any person randomly walking into your clinic has got typhoid is extremely low. But the moment he says, yeah, I got fever for the last 9 days, and so on and so forth, then your pre-test probability goes up. And the diagnostic validity depends on that clinical judgment of what is the probability of the disease even before you do the test. I remember many years ago, I was sitting in the OPD, one 23-year-old lady came. Her story was very simple. She got married 6 months ago. Now she is missing her periods for 3 months. Now it doesn't need a whole lot of clinical judgment to know what is wrong with her. So I took a slip of paper and wrote the pregnancy test, and out she went. And little later she came by the slip. It is written in green ink, positive. She can see it. She was all excitement. She came and gave it to me. So I took it, looked at seriously and said, congratulations, you're pregnant. And she held my hand, thanked me so profusely. It looked as though I was responsible for the whole situation. But my intern was watching. He was moved. He was really touched. And then I went out and another woman came. Her story was slightly different. She was 48 years old. She had tubectomy 25 years ago. Now she is missing her periods by 3 months. Now the guy knew what to do. She wrote pregnancy test. And as luck would have it came as positive. So he looked and read And he looked at her and said, "Congratulations, you are pregnant." That lady almost bit his head off. But this happens on a day-to-day basis. And many of us don't do calculations. Good clinicians judge it intuitively. All I request you to say, put a little number to it, and it becomes really magical. Now, it is important that you understand many of the terms that we use, because diagnostic tests we do so often, but still there's a little bit of lack of understanding all over. Now, let me tell you a story. This relates to a guy called Archibald Cochrane. Have you heard of the name? No. In his name only we started the Cochrane collaboration. And he was the chief of the Medical Council, Research Council of United Kingdom. Now, when he was young, and he was chief of Medical Research Council, he dared to do the following study. At that time, the coronary care units were just coming on. So what he did was, he did a randomized controlled trial. Prior to coronary care unit, if you had a chest pain, who looked after you? The GP. Now coronary care units have come. So all chest pain cases, he randomized to two arms. One GP care, other one to CCU care. Can you do it today? Can't. Anyway, when he finished the study, he presented to the Royal College of Cardiologists. And as the data came, it was magical. The CCU did brilliantly, as compared to general practitioner. The Royal College of Cardiologists, they were thrilled. They patted him on the back and said, "What a wonderful study, brilliant study. I think we should ban general practitioners from treating chest pain." At this point, he said, "Oh, I'm so sorry, I made a mistake. Actually, it is the other way around." Truly, it was the other way around. That study actually showed GP care had a much better prognosis. But history shows that the real thing that happened was CCU came to stay. Why is that? Economics. Unfortunately, a lot of it is money. You look at the whole scan in the United States of screening for prostatic cancer and prostatic surgery. I mean, it's almost a universal thing. And there is very good evidence to show PSA is not a diagnostic marker for prostatic cancer, which we knew many years ago. But American neurologists held on to it. Till recently, I think American Public Health Association has put a very clear dictum: don't use PSA as a screening device. And I mentioned to you because recently there was a move in India to bring PSA as a routine screening program. Because as cars are getting more expensive, we need the money. So the sun source of this will be a prostatic surgery. Now, I'm going to discuss today some of the simple notion about how you interpret results, and you should be wary of it. So you make your decision not because of somebody else is shouting, but you know the numbers and you can make up your own mind. Let me start with a very simple problem. Can you take it down if you have a piece of paper, or I'll write it there. I start with a population of 5,000 each. We'll take the same old story. Nothing else has contributed to epidemiology as much as smoking has done. So we take 5,000 smokers and 5,000 non-smokers. And let us say we have, after a period of follow-up, a long time, 600 heart disease and here 150 heart disease. Now this is our basic data, and we'll try and develop all related to how usually we communicate information. The first measure you do is you calculate incidence of disease among smokers. And if you look at it, it works out to 120 per thousand. 120 per thousand among smokers. And non-smokers, it is 30 per thousand. Okay, I'm going to call this A, and I'm going to call this B. Now that we have done that analysis, what are the next steps? You have incidence of heart disease. Incidence of heart disease among non-smokers. Next, what you do? Yeah. And next step you do is calculate your risk. That is A by B. Now you can, if you're a smoker, you are 4 times more likely to develop heart disease as compared to a non-smoker. That is your basic primary analysis. I got to take you through a slightly difficult journey. Please bear with me, because this is one of the commonest way people pull a wool over other eyes. Supposing I told you I put some money in a bank and they gave me 500 rupee interest. Will you be interested? Well, you would like to know how much money did I put, right? Okay, I put 1,000 rupees and they gave me 1,500, which means I made a 500 rupee after time t. Now, how will you analyze the data? You will analyze the data this way. 1,500 minus 1,000 divided by 1,000 is equal to 50%. Are you with me? That is the way you do your accounts. Somebody said, you know, poor in mathematics. Do you agree with me? Them? Not at all. There's no other branch of science which uses mathematics as much as medicine does. A simple guy will walk into a clinic. In a short while, you'll convert into a set of numbers. He has an age, he has a height, he has got a weight, he has got blood pressure, he has got cholesterol. Everything is numbers, okay? And then doctors, you ask them, how are you matched? Very bad, okay? That's not correct. So what I've done is, watch this, I've calculated the excess money I got, the interest rate. Now just watch. This is the money before putting in the bank. This is the money after putting into the bank. All right? So this is like B. This is like A. Incidence among exposed. After exposure, you got them. So I'm going to write this equation as B minus, A minus B, this equation, divided by B into 100. This is called excess risk. Now I'm going to rub off the rupee, and using this data, we'll see what you get. We will get 120 minus 30 divided by 30 is equal to 300%. That is called the excess risk. The most common measure of association that we use in all scientific literature that is published now. Excess risk is more often quoted than relative risk. What is that? incidence among exposed minus incidence among unexposed divided by incidence among unexposed. Now, what's this? I'm going to divide by the top and bottom with B. What is B? Incidence among unexposed. What do I get? I'm going to divide both A and B. A by B minus B by B divided by B by B into 100. What is A by B? Relative risk. B by B is 1 into 100. Excess risk is simply relative risk minus 1 by into 100. Why did I take such a lot of time explaining to you what is excess risk? The reason is this. Suppose you land up with a lousy relative risk, 1.5. 1.5 is too close to 1. You publish your article, nobody will look at you with respect. Okay? But then you convert that 1.5 to excess risk. How do you do that? 1.5 minus 1 into 100. What do you give? 50%. Eating fried food increases risk of stomach cancer by 50%. People listen to you. That's frightening. Supposing your relative risk is 1.9. Now what is your excess risk? 90%. Fellows will be petrified. Okay? They won't touch fried food after that. Excess risk sounds better. Even a stupid relative risk like 1.2 is so close to 1. But you convert into 20% excess risk, wow, that is something. But I want you to remember that these two terms, relative risk, generally, when it's close to 1, causally speaking, it's shady. Okay? Causally speaking. Recently there was a huge meta-analysis on what? On eating vegetables and fruits and how does it reduce risk of cardiovascular disease. Now I said a huge meta-analysis because the total sample size exceeded 300,000. Big. And what are the relatives they got? 0.98. How close is to 1? As close it can be. And that is not good, right? Fine. So now you know excess risk, how to calculate it. I hope you will put to good use, not to cheat people, but to see through other people's scam. One more notion I want to leave with you. I'm drawing this picture here. This is 120 per thousand. This is 30 per thousand. This is incidence among exposed, incidence among unexposed. Now what I'm going to do is draw here a shaded area. What is the shaded area? That's right. That is the amount of disease smokers would have got even if they hadn't smoked. So in other words, this much of disease can truly be attributed to smoking. So now we have a new term, attributable risk, is equal to risk difference is equal to 90 per thousand, which is equal to A minus B. So A minus B is your attribute risk of the quantum of disease that is directly attributable to smoking. But literature, we don't mention it this way. What we do is, we express it as a percentage of the total disease. What percentage is attributable to smoking? So in other words, it comes it as A minus B by A into 100. And in this case, it would work out to 75%. That is called the percentage attributable risk. Got it? If you don't follow, just put up your hand. We found the difference and express it as percentage of total. A minus B by A into 100. Permit me to do one more little twist. I'm going to divide top and bottom with B. What is B? Incidence among unexposed. And what do you get then? Minus 1 by RR into 100. So the percentage attributable risk can also be calculated as R minus 1 divided by RR. All right? Now I'm going to make a statement. There's a new vaccine coming up for typhoid. New vaccine against typhoid. This vaccine offers 90% protection. This means that 90% of those who receive the vaccine will not get the disease. Which also means 10% may get the disease. Do you agree with me? You agree with me? Okay, that interpretation is wrong. Okay, so as doctors, at least you should know what is the meaning of the word protective effect. So I'm going to show you what it means. We are suddenly into vaccine research. Here is a new vaccine for an exanthematous fever. We gave it to 1,000 people, children, and 1,000 received placebo. In this group of children, 116 in the placebo group developed the disease. Okay? And in this group, in the vaccinated group, 20 developed the disease. That is your finding. Now, how do we calculate protective effect is the question. So this is 2% and this is 16%. %, 16%, A, B. I'm going to draw a shaded area here. What is that? That is the amount of disease the unvaccinated would get even if they received vaccination. So actually, the protective effect is this much. Okay? So the protective effect is going to be B minus A divided by B. Of all the disease among unvaccinated, what proportion can be prevented by vaccination? So incidence among unvaccinated minus incidence among vaccinated divided by incidence among unvaccinated. So you will get an answer as 16% minus 2% divided by 16%. Do you have some? See how much it is? 14 divided by 16 as a percentage. All right? Now let us revisit our question. What does that 87.5% mean? It does not mean 87% of the vaccinated will be protected. What it means is there will be 87.5% reduction in the incidence of disease among vaccinated as compared to unvaccinated. That's a different notion. Let me start the disease. Polio. Pre-vaccination time, if 1,000 children got infected with polio, do you know how many would come down with paralysis? If 1,000 new young babies, unvaccinated, they got polio virus, wild virus, in 1,000, how many will develop paralysis? Point? You're talking about percentage or? Out of 1,000, how many? Approximately 6. Okay? 6 would develop paralysis. 994 will not get the disease. So if you come with a new vaccine and say it offers 90% protection, and say that means 90% of children won't get the disease, doesn't make any sense. Why? Already 99.4% are not getting the disease. What the 90% means is there will be a 90% reduction in the incidence of disease among vaccinated as compared to unvaccinated. In other words, instead of 6 per 1,000, the incidence will fall to 6 per 10,000 with a vaccine which is 90% protective. So that is the notion here. Will somebody explain to me the idea of number needed to treat? Who knows? I'll give you a microphone if I have one. Microphone irka? I'm in Tamil. Maybe. Anybody can explain to me number needed to treat? You know? Explain. NNT. Try. Somebody try. I'll give you the data. From that, you tell me. Sit. When a statin studies came out, first time, simvastatin, they had a large number of people, randomized controlled trial. They followed them for 6 years and then looked at mortality due to coronary heart disease among statin group and placebo group. The difference in mortality was 5%. At the end of 6 years, the difference in mortality was 5%. Question to you is, from this, can you teach me the notion of number needed to treat? Not quite. You're almost there. What it means is that, anybody, you're correct. You just were too nervous to say it fully. Take which 20? You said if you take 20.
20 people are exposed to the statin, one of them will get protection from the.
Correct. Now I'm going to say the same thing. If you treat 20 people with statin, you will prevent one death. How did she get that? How did she figure out 20? I said the difference in mortality was 5%. That's called absolute difference. Yeah. So if the 5% is the difference in mortality, then if it had been 10%, the number needed to treat would have been? If the difference is 10%, the number needed to treat would have been? 10. If the difference between 50%, number to needed to treat would have been? 2. So all you have to do is take the number needed to treat, write down 5%, 5 per 100. Turn it around, 100 by 5 equal to 20. So any absolute difference you get, you can convert into number needed to treat. So now you have figured out. So, it's a good idea to put everybody on statin? Now before you answer it, you should write it fully. If you treat 20 people, you will prevent one death. But how long do you have to treat them according to study? 6 years. That is 6 into 365. 6 years you treat, you will prevent one death. At that time, the simvastatin cost was 30 rupees. So if you spend so much money, you will prevent one death. Do you have a Korean calculator, somebody? Tell us how much it costs to prevent one death. $13 lakh. Now I'm not saying it's big or small. I just told you how much it was. Now you have to decide whether to prevent one death, we can afford to spend that much money. Okay, that is a different question altogether. But that's how to interpret and do it. Okay, now, what did we discuss today? We discussed a little bit about diagnostic test and asked the question, please be very respectful of specificity. Okay? And if you don't look at it, you will not know how much of false positives you are gathering. We looked at the issue of interpreting the results of that. We also looked at relative risk, excess risk, attributable risk, and things like that. Now, do you have any questions?
So how did we get the 20 figure? Could you explain?
20, yeah? Very good. The study I quoted, I gave the incidence of disease among two groups and looked at the difference between the two groups. In this particular one, the statin had a lower mortality and the other one had higher mortality. The difference was 5%. 5 per 100 was the mortality. The next question we asked is, how many patients should you treat before you prevent one death? That is the notion of number needed to treat. Instead of saying 5% different, now you convert into And I said to get that, what you do is turn the percentage upside down. That automatically gives you number needed to treat. Helps you in control. Any other question? Pardon? Well, what happens is attributable risk is different. Absolute something. So thank you for reminding me. You remember the 82.5% we calculated? The vaccine study, and we calculated it as B minus A divided by B into 100. Supposing you were to divide both top and bottom with B. See, I have this bad habit of dividing top and bottom with B. What would you get? You will get 1 minus relative risk into 100. Okay? So the message you have to take home in research is, usually in the vaccinology, the vaccine incidence among exposed will be lower than incidence among unexposed. In other words, the relative risk you calculate will be less than 1. So let's say you get relative risk of 0.5. That means protective effect is 50%. 1 minus relative risk. If relative risk is 0.2, that means your protective is 80%. So on and so forth. That will be a better method to look at it then. Any questions? As soon as I asked, she did this. It's like, I refuse to ask any question. Thank you very much. It's a pleasure talking to you.
Thank you, Dr. JP. Always wonderful to have you, and we'll have you again and again. I'm sure every time we learn a lot.